Chetan, is it done? Shall we begin?
Yes, sir. Just give me 1 minute.
Yes, Omkarji, can we start?
Just a minute. Just a minute. Okay. Please start, Chinmay sir.
Yes. Good evening, all. At the outset, on behalf of Alkem Laboratories Limited, India's fifth largest pharma company, I welcome our respected moderator, sir, and all our eminent panelists and all the doctors who have joined us for today's anti-thrombotic debate. As you all know, at Alkem, it has been always our endeavor to partner with medical fraternities and healthcare professionals. And in this difficult time also, we are continuing to do so. To help us to navigate this session, today we are extremely fortunate to have Dr. Bikash Majumdar sir with us, and sir will be our today's moderator. I take this opportunity to welcome Dr. Bikash Majumdar sir for this anti-thrombotic debate. Dr. Bikash Majumdar sir is a senior consultant and intervention cardiologist of Apollo Gleneagles Hospital, Calcutta. Sir was formerly specialist registrar of University of Wales, Cardiff, UK, and formerly intervention cardiology fellow of Trinity Hospital, Zurich, Switzerland. With this brief introduction, I welcome you, sir, in this anti-thrombotic debate.
Thank you.
I take this opportunity to welcome Dr. Mridul Bera sir as well. Dr. Mridul Bera sir is a consultant physician in Narayana Hospital, Howrah, and consultant physician and critical care specialist in Indus Nursing Home, Howrah. Sir is a provider of ACLS course and founder member of Howrah Town Diabetes Society. And sir is a principal investigator of Indian Phenotype Registry of Type 2 Diabetes mellitus patients. Sir is a member of ADA and ESC. With this brief discussion, I welcome you, sir, Mridul Bera sir, in this anti-thrombotic debate. I also take this opportunity to welcome our renowned panelist, Dr. Shilanjan Roy, sir. Sir is a consultant interventional cardiologist presently attached with Arjikor Medical College and Hospital. Sir is a visiting consultant in Charnock Hospital and North City Hospital. And sir happens to be the institutional topper in DM cardio exam in 2018 from Arjikor Medical College and Hospital. Sir is a member of ESC and international associate member of ACC and life member of API, Indian Academy of Echocardiac Society, Heart Failure Society, and RSSDI. Welcome, Dr. Shilanjan, sir, in this anti-thrombotic debate. I take this opportunity to welcome Dr. Monish Shah, sir. Sir is a consultant interventional cardiologist attached with Arjikor Medical College Hospital. Sir is practicing in and around North Chobbish Pargona, Barakpur, and Calcutta area. Sir is a consultant cardiologist of Apollo Clinic, Barakpur. I welcome you, sir, in this debate. And I also take this opportunity to welcome Dr. Navarun Roy, sir. Sir is a MD DN cardiologist attached with Apollo Gleneagles Hospital, Calcutta, an interventional cardiologist in Salt Lake area with more than 13 years experience, and completed his DN cardiology from IPG MER, Kolkata. With this short, brief introduction, I welcome all my renowned panelists, eminent panelists, and I hand over it to our moderator, sir, Dr. Bikash Majumdar. Over to you, sir.
Good evening. Today we are going to have a panel discussion and debate on this antithrombotic as well as antiplatelets that we are using in our day-to-day practice. Now, it will be a case-based discussion, and we will present different cases, and we'll discuss on how we'll discuss among the panelists what's your opinion about managing these cases. So that will be the kind of format that we'll be doing. And as we know that there are many antiplatelets are coming over the last few years in the management of acute coronary syndrome. And we will take each and every case as a context and see how we can use these antiplatelets. So what are the advantages and disadvantages, and what is the comparison between different antiplatelets that we are having in our armamentarium nowadays. And the second section, we will discuss about the antithrombotic management, particularly for stroke prevention in atrial fibrillation. And we all know that warfarin has been used for many years, and but recently, with the advent of the NOAC, the novel oral anticoagulants, the management has changed quite a lot over the last few years, and we'll try to understand that which kind of NOACs and where, in which cases, we should be using in a rational way. So we will love to have the opinion from the panel regarding these two main broad category of patients. So to start with, may I request
Yes, sir. I'll present the case.
Mahapal to present the case, please.
Sure, sir. This is the case 1, wherein there is a 60-year-old male who comes in emergency department complaining of sudden onset of chest pain since half an hour. He is a known case of smoker, diabetic dyslipidemia, hypertension, and IHD. He has a family history of IHD and diabetes, history of MI 1 year back with angioplasty done to LAD and in clopidogrel, taking irregularly. ECG shows old anterior wall MI with negative cardiac biomarkers and BPs of 150 over 90 mm of Hg and pulse of 84 beats per minute, which is regular, and is on the medical management. So these are the following pointers where we will be discussing upon that which antiplatelet should be chosen for the particular patient to manage upon. I would again hand over to Bikash sir to ask respective panelists for their views and opinions.
Right.
Over to you, Bikash sir.
So again, so you can see that this is a 60-year-old high-risk patient who already had myocardial infarction and had stents. And definitely, he is coming back with, again, chest pain, but without any acute coronary syndrome. And he is irregular on clopidogrel, and cardiac biomarkers are negative. That means he didn't have any acute syndrome, but having chest pains. So it could be an unstable angina presentation in this particular patient. So first, next slide, can you just change it? First, I would like to ask Dr. Shilanjan Roy that what's your view about the antiplatelets in this particular case, where we have already seen that this patient is little bit non-compliant as far as the clopidogrel is concerned. And do you have any other views regarding this kind of patients? I think we get it.
I beg your pardon, sir. Can you please give me 5 to 10 minutes? Right now, just now busy. I'll be able to join the video within 7 minutes. Can you please ask other panelists to proceed with the discussion?
Right. Okay. Fair enough.
I just was busy with the patient. Thank you very much.
Okay. And Dr. Navarun Roy.
Yeah.
Your view.
Hello.
Yeah.
Can you hear me?
Yes, I can.
So this is a post-PTCA, post-MI patient. Already 1 year has been elapsed, and now he has presented in a year with chest pain, kind of unstable angina. So, and considering his multiple risk factors, it is a very high risk for future ischemic event also.
Yes.
So in this particular case, I will consider ticagrelor over clopidogrel. And as the 1 year has already been elapsed, so dose will be 60 milligram twice daily, along with ecosprin 75 milligram.
So probably you are referring to the Pegasus study. And
yes, Pegasus study.
And this is 60 milligram twice a day ticagrelor on the top of the aspirin, as is a high risk patient, as he already had a STEMI and he has a lot of risk factors, and coming after a year with recurrent chest pain. So how long do you think that you should be considering ticagrelor in this particular patients?
If there is no bleeding complications and patient can afford ticagrelor, then it should be continued as long as possible?
So, to a very indefinite period, I think it's a little bit vague. Means I don't know how long is the best for this kind of patients, but yes, quite a lot of patients can actually have up to 3 years of 60 milligram twice a day ticagrelor. But if you ask me in my clinical practice, probably I will try to do an angiogram here as well, repeat angiogram in this particular patient. What is the problem?
That is necessary.
With this patient, and then decide accordingly. So though 60 milligram ticagrelor for a longer period of time, the evidences are coming up. In my own personal practice, I haven't adopted that particular approach yet. The only concerns which I have is a long-term antiplatelets and the issues of bleeding that you already have mentioned. But definitely these kind of patients all should have a dual antiplatelet for at least 1 year. In these patients, particularly, they prescribed clopidogrel, but if they would have prescribed ticagrelor from the very beginning, that would have been probably more appropriate nowadays as far as an ACS is concerned. And each and every patient of ACS, yes, if you can give 90 milligram twice a day of ticagrelor along with an aspirin at least for a year, and particularly in those high-risk patients, after 1 year, 60 milligram twice a day, the evidences are coming up. So this I must say at this moment in this particular patient. So that is what I had to talk about. And what about aspirin? Do you think that the role of aspirin nowadays? Do you think that the evidences are coming to go away from aspirin?
Yes. Yeah. Ticagrelor monotherapy, there are two landmark trials, TICOS trial and Twilight trial, which are showing only 3 months of dual antiplatelet followed by ticagrelor alone can give similar kind of clinical benefit without lesser bleeding risk. So it is coming up.
Particularly in those patients where you have high bleeding risk, means clinical practice often we see that some patients we had to do an angioplasty and then the patient has been diagnosed with a GI ulcer or a GI cancer who requires a surgery. Then you can't continue the dual antiplatelet for 1 year. So if those kind of patients has an onyx stent or a biofreedom stent, then probably 3 months of dual antiplatelet followed by ticagrelor only without dropping the aspirin is one of the options. Any other view, Dr. Beda?
No. Actually, I am on the same opinion that if our patient is definitely a high risk patient already, patient has an MI, and the patient has also the history of diabetes, the dyslipidemia, and again the patient is coming within already the patient has already been stent has been implanted. Now patient is suffering from the post-infarct angina, so again the patient is suffering from acute coronary syndromes, and also the patient is already taking the clopidogrel and probably aspirin. The aspirin was not mentioned here, but again actually we see the patient is taking the dual antiplatelet of aspirin and the clopidogrel, and also the patient is taking clopidogrel irregularly.
Yeah.
So in that case, for that reason the patient suffered again an acute coronary syndrome, and so as the patient risk is very high, I will definitely change from the clopidogrel to the ticagrelor, and already has been studied in the Pegasus trial, and already the patient has already done the 1 year of the post-infarct. So I will start the patient with the aspirin and the ticagrelor at 60 milligram twice daily, and for at least for me for 3 years, because if we just continue the dual antiplatelet therapy of this aspirin and the ticagrelor, maybe the 60 milligram twice daily, and the prolonged therapy will definitely increase the risk of bleeding. So at least for 3 years, I will continue the dual therapy, as the TICOS and the Twilight trial also proved. And after only the 3 months of dual antiplatelet, if you change to the monotherapy within only the ticagrelor, that will be definitely as comparable to aspirin and the ticagrelor. And but the main fallacy of that study, that is the Twilight and the TICOS, where the ticagrelor has not been compared with the only aspirin therapy. So this is the one concern. So I will just continue for at least 3 months, 3 years of this ticagrelor 60 milligram and aspirin, and then I will just continue the patient with either the aspirin or the ticagrelor. So to my choice, I can continue. When we continue the monotherapy, I will choose definitely the ticagrelor 60 milligram twice daily.
Right. That's a very nice comment. One thing I just want to mention that yes, ticagrelor longer period of time is only licensed for these kind of high risk patients who already had multiple risk factors, had a STEMI, and then after 1 year coming up with another episodes. Not for all of the patients who had a stents. We actually accept those high risk kind of patients who after having a stents and MI after 1 year having recurrent symptoms. Those are the patients where we are thinking of prolonging the dual antiplatelet treatment. Otherwise, in a normal bog standard patient, probably 1 year of dual antiplatelet is enough, because majority of the time we are trying actually to reduce the length of the dual antiplatelet in the current practices, and a lot of studies are coming up. So Dr. Shah, so do you have any other views or regarding the uses of ticagrelor in this kind of high risk patients, particularly who already had an infarct a year ago, had a stent, and after a year coming up with recurrent chest pain? But of course, we have to mention in this particular patient that this patient has a compliance issue. So he couldn't take clopidogrel properly for 1 year. So I think, Dr. Shah, you get this kind of patients in your practice as well. When you struggle to get proper compliance from the patient, then how do you approach this kind of patient to stick to the drugs, particularly when someone has an angioplasty and stenting and then having recurrent symptoms? Do you take any strategy in those kind of patients who has non-compliance issue, particularly with antiplatelet?
The patient in this case was on irregular intake of clopidogrel. We can't blame clopidogrel in this case because the patient was non-compliant, and the patient was on aspirin and background myocardial infarction and stent, history of PTCA. And it is a high risk unstable angina patient, needs to be treated with angiogram. We have to early invasive strategy we have to take, in spite of whatever property is positive or negative. The first thing. And next thing is that I have to know what was the reason of compliance, because in till date, ticagrelor is costly than the clopidogrel, and we have to do if the patient, if we take we can get an appropriate atmosphere to treat the patient, I have to go for angiography plus minus revascularization in any form, and we have to ask the patient whether he can continue ticagrelor or not. If the patient can afford ticagrelor, I will always prefer ticagrelor over clopidogrel. And till date, all the evidences are coming. There is no recommendation yet that no class 1 recommendation of giving dual antiplatelet beyond 1 year. So I will go for ticagrelor plus aspirin for next 1 year, 90 BD plus 75 aspirin, and after 1 year, I will continue with single antiplatelet drug. Currently, we can go for either we can follow the PKS as the 60 milligram BD ticagrelor or aspirin 75 milligram OD. And if my strategy will be 1 year ticagrelor twice daily plus aspirin 75, then 60 milligram ticagrelor BD for another 1 year, then aspirin monotherapy. At present scenario, this will be my strategy. Okay. And if the patient is yes, sir.
Yeah, carry on. Yeah, carry on.
Yeah, if the patient can't afford ticagrelor, that this is costly, I can't afford, then I will go for clopidogrel and plus aspirin for 1 year, followed by, because we are, as you told earlier, that we are receding from aspirin, and then after 1 year, I will go for clopidogrel plus only clopidogrel after 1 year, if the patient can't afford ticagrelor.
Only
My
single
first preference will be,
that is not a crime, definitely. So you can either give an aspirin or you can give a single antiplatelet clopidogrel, and only in those kind of high risk patients where we are thinking of extending ticagrelor for a few more years, 60 milligram twice a day. So that's what I would be. Right. So any other comment from the panelists regarding this particular case, or we can move on to the next one?
Now, is there any role of Prasugrel in this case?
The thing is, in the long-term studies with the Prasugrel for 3 years, I am not aware of that is any studies with the Prasugrel for 3 years or 4 years. The
Yes, sir.
Prasugrel,
As there is a compliance issue, the question coming compliance issue. That's why I'm asking.
twice a daily ticagrelor versus once daily Prasugrel. So you can say that, but I don't think I'll be able to back it up with evidence.
Now, ticagrelor is available in an affordable price. That is one advantage we have.
Yeah, but anyway, so affordability we are not discussing here. It's, we are discussing probably how we should be treating our patients best. So there are a lot of reasons for non-compliance. Not only the affordability is one of the reasons, but there may be a lot of other reasons not to take tablets. That's
lower hypoglycemic events with vildagliptin compared to sulfonylurea.
sorry.
Comparison 52 weeks add-on to metformin, vildagliptin and metformin.
But I can't get your question. Sorry. Your voice is breaking. Hello? Hello? Sorry, can't hear. Right. So, can you change the slide, please?
These are backup slides. So shall we dwell on this, or we can move to the other case?
Right. So we all know this. This is how we treat the ACS. So this is just to recapitulate that whenever we have ACS, means either we have screening or the first thing is we load them with dual antiplatelet, aspirin 300 milligram with ticagrelor 180 milligram, or a clopidogrel 600 milligram, or prasugrel 60 milligram. And then we take this patient to the cath lab to do the primary PCI if we have a PCI capable hospital. If we don't have a PCI capable hospital, we do a thrombolysis with and the thrombolytic agent, either a tenecteplase, the better one, or streptokinase if we don't have tenecteplase. And once you thrombolyze the patient with tenecteplase, then we send this patient to a PCI capable center with the view to have an angioplasty with from 3 to 24 hours of thrombolysis. That is called pharmacoinvasive strategy. And then after that, the patient need to continue on the aspirin and another antiplatelet, which is ticagrelor 90 milligram twice a day for 1 year, along with the beta blocker ACE and the hydrostatin, which is either 20 or 40 milligram of rosuvastatin or a 40 milligram atorvastatin. That is the box standard treatment of the STEMI that we all know about. In the non-STEMI, the similar thing, you don't need to do the primary, but as soon as possible, you take these patients to the lab, identify the culprit lesion, you do the angioplasty, again, load them with dual antiplatelet and continue the similar kind of treatment for 1 year at least. And then, depending upon after 1 year, you can switch on to the single antiplatelet. In the high-risk patients who are bleeding, that's where the Twilight study comes, and where at least after three months of dual antiplatelet, you can switch on to the clopidogrel only, ticagrelor only, rather than dual antiplatelet, particularly in those patients who are at high risk of bleeding, and particularly if you're using onyx stent, you can actually shorten the dual antiplatelet 1 month, and then you can switch on to the single antiplatelet after a month, and particularly on those patients who have high bleeding risk, not for everyone. Again, I am re-emphasizing that. So this is not, the guideline hasn't changed from 1 year to 1 month. It is particularly those patients who have high bleeding risk then, and you are using onyx stent, then you can go for 1 year, 1 month of dual antiplatelet and then change to single antiplatelet treatment. So onyx 1 is another study. So onyx stent and biofreedom stent, these are the two stents where we have evidences of shorter dual antiplatelet treatment if necessary in high bleeding risk patient. But here, this category is different. These patients already had a STEMI, and after 1 year coming with recurrent anginal pain. So these are the higher risk of having recurrent events, recurrent MES events, like another STEMI or another non-STEMI. In this particular kind of patients, we can consider prolonging the dual antiplatelet treatment, particularly with ticagrelor 60 milligram twice a day, and that could be up to few years, up to 3 years or 4 years, along with an aspirin. But I must say my own experience regarding this is limited, and still I follow 1 year of dual antiplatelet and then to switch to a single antiplatelet. And if this kind of patients comes back with further pain, then we rather see the patient's angiography and decide accordingly what is the cause of this recurrent pain rather than just prescribing tablets. So if we can see that there is some issues with the stents, or there's a new blockages in new part of the artery, then definitely we need to treat that. And if we put another stents in another artery, then again the cycle of 1 year of dual antiplatelet goes on. So that is a kind of approach I take in my clinical practice. So I think that's enough for this particular case. Then we should move on to the second topic regarding this AF and anti-thrombotic strategy.
Can I give one last comment? Can I give one last comment?
Yeah.
Can I give one last comment?
Of course.
Regarding the Themis PCI, when you just see the Themis PCI, all the patient are diabetic patient, that stable coronary artery disease patient was given the ticagrelor, and the whole trial that is definitely not a negative trial. But if you go for the subgroup analysis in the Themis PCI, those patients who have undergone PCI, that group was definitely been benefited with adding up the ticagrelor. So our patient is already the diabetic patient, and also the patient has history of acute MI in that 1 year. So this is another example whether we can use the ticagrelor in this patient for a little longer.
Yes, that's what I'm saying. It's definitely a high risk patient. I fully agree with you.
Okay.
Sir, can we move to the next case?
Yes, you can, please.
Yes.
Okay, sir.
Pankaj,
So coming to the next case, which is on the selection of anticoagulant in stroke prevention in atrial fibrillation. So here is the second case. There is a 69-year-old man presented in emergency department with palpitation of atrial fibrillation and was on warfarin in the past, but not taking regularly warfarin. He has a history of hypertension and diabetes since 16 years and on medications. The patient has a history of IHD since 10 years, only on aspirin 75 mg OD, and history of stroke 3 years back. He has normal hepatic and renal functions. For several months, his INR readings have been fluctuating outside of the therapeutic range. ECG shows AF, 2D echo shows compressed left ventricular function with ejection fraction of 40%, normal valves, vascular dysfunction, no clots and vegetations. Coming to the carotid Doppler, it shows minor bilateral plaque and present INR is 1.6. So these are again the discussion pointers where we will be discussing upon which anticoagulant to be chosen for managing that particular case. So over to you again, Dr. Vikas, sir.
Right. So again, this is 69-year-old man, as you have already said, presented with palpitation, history of atrial fibrillation, was on warfarin, again non-compliant, diabetic, hypertensive, and previous history of stroke and LV dysfunction. So he has all, CHAS-VAS score. If you do it, it's extremely high. So there is no doubt in this particular patient that we need to anticoagulate this gentleman. Next slide, please. Yeah. So this time Shilanjan is back with us. Hello?
Yes, hello, sir.
I would like to kind of clinical practice. So you will agree with me that these patients already had a stroke and a very high CHAS-VAS score. The risk of recurrent stroke is extremely high.
Yes, absolutely.
So how do you approach this kind of patients? Regarding stroke prevention vis-a-vis the bleeding issues as well.
This patient will definitely be in view of non-valvular atrial fibrillation. He is a class 1 candidate for receiving DOACs or NOACs. So we have to choose among the available NOACs that will be best suited for him, whether dabigatran, rivaroxaban, or apixaban. And there is no doubt about that. He has to be shifted to a NOAC for better outcomes, reduction of stroke events, as well as a reduction in hemorrhagic events, all. And because the time in therapeutic range is also poor, it seems, with warfarin in this patient. So there is, no point of doubt that this patient needs to be switched to a NOACs as soon as possible.
So how do you assess, do you really assess the bleeding risk while you're prescribing NOACs or even warfarin in your patients, and how do you deal with it?
The disturbance.
And you're not
Yes,
sure.
bleeding. Yes. Bleeding risk usually, the thing is that, as we all know, that CHA2DS2-VASc score, whenever the patient will be having high CHA2DS2-VASc score, the Hasbled score will also be on the higher side, because the risk factors are almost common in both the risk calculators. So we have to assess the bleeding risk, at least if at all, if you cannot calculate, it will be prudent to objectively calculate the Hasbled score. And if it is more than 3, the bleeding risk is high, then we have to weigh the benefit to risk ratio in that patient and explain the patient. In most of the cases, particularly in this patient where the CHA2DS2-VASc is very high, the patient will, in all cases, will benefit from oral anticoagulation with newer NOACs, unless and until the bleeding risk is prohibitively high because of some liver disorders or other coagulopathies. So he will be requiring, but in certain cases, very elderly, frail patients with prior history of bleeding or having liver disorders, we have to, in that case, risk benefit regarding use of NOACs. Assess the risk to benefit ratio.
Nabarun, do you have any particular choice of NOACs depending upon the characteristics of any patients? Can you hear me, Nabarun? I think.
Hello. Hello.
Can you hear me, Nabarun? Do you have any choice of NOAC in depending upon the characteristics of any patient?
Yeah. If we evaluate the studies of NOACs, only dabigatran 150 milligram twice daily have a clear superior benefit over warfarin. Apart from that, neither rivaroxaban nor apixaban, in case of stroke prevention, they are non-inferior to warfarin, but they are not superior. So in my opinion, I will prefer dabigatran 150 milligram twice daily, because this gentleman doesn't have any GI symptoms or any history of GI bleeding at all. So I will prefer 150 milligram dabigatran twice daily over other NOAC.
So other thing is regarding the doses of dabigatran, as you said, it's 150 milligram twice a day. In which kind of patients do you consider reduction in the dose? It's 110 milligram twice a day instead of 150 milligram.
No, number one is the age. If the age is high, more than 75 years of age, and number two is the renal function. If the creatinine clearance is less than 30 is contraindicated dabigatran. Less than 50, then we have to think about 110 milligram twice daily. If it is lesser and elderly, we have to think about 75 milligram twice daily.
Right. And Dr. Bera, I would like to ask you one thing, regarding prescription of the NOAC. For example, rivaroxaban is a single dose, apixaban you have to give twice, dabigatran you have to give twice. Do you consider these particular once versus twice daily dose while you are prescribing these NOACs for your patient?
For me, definitely the once daily doses definitely will be suitable for the patient because of the compliance issue. But when you see the comparison between these NOACs, between the dabigatran, rivaroxaban, and apixaban, there is nothing particular I will signify that it is better than the other. But what I suggest then, I used to give the patient of dabigatran is 110 milligram twice daily more commonly than the 150 milligram twice daily, because I think it is more safer. Though the study has been saying that all the 150 milligram twice daily, it will give you the better result, and all the study, the RELY trial, and also all the other study that will give you the enough benefit that has been seen with the 150 milligram twice daily. But I think the 110 milligram twice daily in our scenario in the Indian patient, it is quite okay.
That is not evidence, is it? So
yes, but
there are indications for giving 110 milligram twice a day, as Dr.
yes,
the patient is very
yes, but I think that it is more give you the more safety than the 120 milligram twice daily. Though the 120 I used a lot, but I think in elderly patient and also renally compromised patient, I will give you the 110 milligram twice daily or the 75 milligram twice daily. And if the patient is definitely renally compromised, I have to choose between the apixaban and the dabigatran 110 milligram or the 175 milligram. So the choice definitely will go on to what kind of patient we have, that what is the patient age, what is the breeding risk about the patient, what the power of efficacy we want to give the patient. So we have to choose between this all these things, the dabigatran, rivaroxaban, apixaban, because endoxaban probably is not available in our country.
Right. Who would like to continue warfarin in this particular patient? Would you like to continue warfarin?
No. Actually, patient is not a compliant patient, and patient have to take the, if you prescribe the patient the warfarin, the patient have to take the, definitely go for the INR and every 4 weeks or 5 weeks intervals. So in this patient, as the patient is having the recurrent stroke and also the patient is not compliant with this, the medication and also the INR issue, so I'll definitely shift the patient from the warfarin DK to the NOAC. That is in my point, that will be the safer option.
Right. Dr. Shah, means regarding the prescription of this NOAC, not every NOAC has got an antidote, and warfarin has an antidote for, for example, vitamin K, and dabigatran has an antidote. Does it influence your practice while you are practicing or prescribing NOAC? Hello? Dr. Manish Shah?
Monish sir, you need to unmute. Your mic is muted, sir.
Okay. Yeah. Am I audible?
Yes, now you are audible. Yes.
Although it is theoretically available antidote of dabigatran, but once the patient on it is practically very much impossible to give antidote to the patient. Keeping that in mind, we have to be cautious.
There is a antidotes available, and there is a helpline for that. You can actually use that and can give antidotes if necessary.
Yes, I know that, but practically, if a patient in the village needs, and there is a problem, it is not available like vitamin K or some fresh frozen plasma. That is the thing, and we have to keep it in our mind. But in practice, we give, we don't hesitate because of this, because of relatively unavailability of the antidote. We give, sir. I will give. Obviously, I will give because dabigatran NOAC is class 1 recommendation over DKA for prevention of stroke. We have to give, and because this patient particularly, sir, it is very much there is a compliance issue. P-time INR, it is very much difficult to maintain, and in our practical experience, P-time INR is a very variable parameter. A same patient, same dose, we will get different reports from different labs. So that is the very bad thing with warfarin or acetrom, that we can't maintain the P-time INR, and that is the thing. Sir, I will definitely write dabigatran, rivaroxaban or apixaban, keeping everything in mind that antidote is relatively unavailable or like that. I will write, sir.
Okay. Now, regarding, the INR, as you said, that INR is a problematic thing. If we're getting INR every now and then in our country, and It varies so much from one lab to another. It often very confusing, and I find it in my practice to continue, dosing warfarin depending on those variable lab results. So one day you get 1.6 from one lab, and the same time
Yes,
from
sir.
another lab you get 2.5 or 3. So I have seen in my own practice as well. So that makes it very difficult for us to dose warfarin in those kind of patients. But other thing we have to take into consideration, for example, this is a very high risk patient for recurrent stroke, and you prescribe him a NOAC, and then these patients can't afford it. And then the first thing they do is they stop the NOAC. So I don't know whether do it in your practice or not. I always, whenever I am starting someone on warfarin anticoagulation, I give both the choices to them actually. And I say that, you can take
Yes.
warfarin with this caveat. That means it is a cheap drug, but you have to do recurrent INR, and you have to be in touch with me either in a phone or whatever, so that I can recurrently change the dose accordingly, so that your INR is between 2.5 to 3. So this education is important while we are prescribing uh, any anticoagulant to any patients. Otherwise, if we just write you take 2 milligram or 3 milligram, that's probably not the right way of prescribing, because many times patient will be non-compliant if you are not explaining them the anticoagulation treatment, which I found in my own practice. So every time I start an anticoagulation, I explain that this is a agent which I am giving to prevent stroke. At the same time, it will liquefy your blood, so chances of getting bleeding is high with this medicine. So either I am prescribing a warfarin or NOAC. This is my first statement. So in order to give this medicine safely, if you are taking warfarin, we have to make sure that you check these blood results every now and then. Be in touch with me so that I can change the dose accordingly, so that your therapeutic INR remains between 2 and 3 or whatever you choose according to the patients. And majority of them actually diligently do their INR test and get back to me, and I dose accordingly. So that's one thing. And second thing, I said that yes, you can be out of this hassle. You don't have to use this INR. If you choose this NOAC, it will be a little bit expensive. There will be no antidote if there is any bleeding. So be aware of the bleeding. If there is any bleeding, you need to bring yourself to the hospital so that we can assess you and we can do accordingly. And if you can afford, so please, you don't stop it. You are not, you shouldn't try to stop it without any medical advice. Would you prefer to have this NOAC and it will cost you this much in a month? And the patient says, no problem, doctor, you give me NOAC, I straight away write the prescription of a NOAC. But what I don't do, I just write a prescription of a NOAC. Patient goes out of the prescription and finds that it is warfarin is 30%, and this is 20 rupees or 30 rupees or 50 rupees. The first thing he does, he doesn't buy the NOAC. That is a disaster. So at least he gets a 30% warfarin and then gets INR and be in touch with me so that he's adequately protected. That's better rather than having no NOAC. Only one prescription of NOAC for a month, and he finds that it is highly expensive and he stopped that. So that is a disaster. So patient counseling is very important to start with when we are starting this anticoagulation. At the same time, when we are explaining the risks of bleeding and vis-a-vis thrombosis. So that's the approach I take. I think most of you take this kind of approach as well. And in that way, I find that compliance is better with my patients. So either they are on warfarin or acetrom, or they are on NOAC, because we had a discussion of extra 5 minutes, and then they can make their mind and choose what they want to take according to their availability, according to their finance, and according, warfarin, we have been using that for years together, decades together. NOACs are as good as warfarin, as Navarun says. Only dabigatran shows a superior benefit compared to warfarin. But yes, if the NOACs, there is less chances of intracranial bleeding compared to the warfarin, as we all know. But as far as the anti-thrombotic effect and stroke prevention is concerned, it is non-inferior to warfarin, as the other NOACs are concerned. So, and at the same time, where we are prescribing, we need to think about other parameters as well. Shilanjan, do you routinely?
Yes, I want to make a point, sir. I want to make a few points regarding the thing that you have mentioned and discussed. That firstly, in this scenario of patients, at this present point in time, as far as the guidelines and the overall situation goes, I would not possibly explain, give the patient two choices of either VK or NOAC. I will straight away, persuade the patient to go for NOACs only for
Now,
few reasons. I want to, no, for few reasons.
It costs 50 rupees a day and
No.
patient can afford it.
Because first cost has come down. That is a big thing. Because when a single tablet of dabigatran used to cost 75 rupees and the cost of therapy per day was 150, then it becomes a hindrance. Now when the cost has come down to 15 rupees per day, or maybe for rivaroxaban maybe
30 rupees, yeah.
50 rupees per day 30 rupees, or rivaroxaban maybe 15 rupees per day. I won't think about warfarin, because the first reason is that one is non-inferiority or rather superiority in certain studies. Second is that the risk of bleeding is much lesser, significantly less. Risk of intracranial hemorrhage and life-threatening bleeding is significantly lesser with all DOACs. That is a big advantage. It may not be statistically significant or superior, but at least the risk of major bleeding is lower. That is a big advantage. The other benefits of variable pharmacokinetic and pharmacodynamic effects and food and drug food interaction, these factors can be negated. And if we think that what should be the cost of hospitalization because of increased bleeding, or the cost of recurrent checking, getting INR checked at regular intervals and visiting physician clinic, maybe the total cost will be almost similar, if not less, with an NOAC. And third thing is that even in the developed countries, patients who are highly compliant, the time in therapeutic range with warfarin has hardly been shown to be not more than 60%. So it is highly unlikely that in our country, particularly in patients who are coming from peripheral areas or villages, they are however compliant the patient may be, it will be very difficult to maintain a time in therapeutic range of hardly 30 to 40%.
I'd like to interrupt you in that particular case, just for the sake of debate. So you said that your therapeutic range is probably 60, the INR therapeutic range is probably 60%, right? Now, with the warfarin, just for debate, I'm saying I also prescribe NOACs, right? But just for a sake, that with the warfarin, when we check the INR, we know where we stand as far as the anticoagulation status is concerned. When we are giving a NOAC, we don't know where do we stand as far as the anticoagulation status is concerned. Whether the patient is therapeutically anticoagulated or not, how do you know? What do you
But possibly that is an advantage of NOAC. There is no need to check it.
Test.
Yes, there is no need to check it. You just fire and forget about in case of NOAC. That is an advantage. Like the same thing that like we don't check antiplatelet activity while after giving antiplatelet drugs, or a degree of platelet inhibition in lab. Similarly, that is an advantage of NOAC that we have to accept, that it is the sheer mechanism of the drug by direct inhibiting the factor 10A or by inhibiting the thrombin directly, that we do not need to check the therapeutic efficacy of the drug, and we just give a fixed dose of the drug.
So if you give dabigatran and check, this factor 10A or and how many patients do we check? We never check that. So
we never check it because it's not available or it's neither recommended.
Not platelet activities either. And we all know that there is 30% up to 30% of the patients of
platelet resistance will be there. Yes,
there's a resistance, and that's probably one of the major issues when we are talking and discussing about ticagrelor, that we don't have the resistance and all these things in today's world. But yes, as I said, I'm being devil's advocate in a country like us where finance is an issue and where we are checking an INR. We at least know that status of the anticoagulation of this particular patient is, but if you prescribe dabigatran twice a day and send the patient to the village and he takes once a day and you are pretty sure that patient is having, proper anticoagulation, I don't think that's the.
I think, sir, I would take that extra 5 minutes to explain the patient regarding the need for diligently adhering to NOAC therapy, rather than giving him a choice of NOAC versus DOAC in these patients, in this subset of the patient.
So in this subset
of them, I will rather devote a couple of minutes or maybe 5 minutes to explain the benefits of NOAC and the importance of adhering to NOAC therapy, or rather explaining the advantage of NOAC over warfarin if I am considering switching from warfarin to NOAC therapy. that why I am switching to a more costly drug rather than the much cheaper alternative.
No, that's
So
fine.
that will be my approach in this present scenario.
Yeah, that's
Definitely the thing was different couple of years back when it costed a lot, and now the cost has at least come to a range, and I mean within an affordability limit for most of the patients. Yes.
In the non-valvular AF
Sir,
patients, definitely. Yes. And
Sir, I want to.
yeah, carry on. Yeah, Dr. Shah. Hello, Dr. Shah. You unmute yourself, please.
Moniz,
Sir,
unmute.
please. Unmute. Yes. Yeah. Am I audible?
Yes.
Am I audible now? Yes.
Yeah, carry
Sir,
on.
if we consider the parent trial of all these NOACs, that is Relay for dabigatran, that is Rocket A for rivaroxaban, and Aristotle for apixaban, we can see that in dabigatran 150 BD and apixaban 5 milligram BD is superior to warfarin in prevention of thromboembolic stroke or systemic thromboembolism. Whereas rivaroxaban, that is Rocket AF study, rivaroxaban is non-inferior. What Navarunda says. But I want to ask, sir, if you have to have this cafeteria approach, cafeteria of choice, that you can give dabigatran, you can give rivaroxaban, you can give apixaban, what drug you will choose?
Sorry, what?
Which drug you will choose, sir? That is, you will choose dabigatran or rivaroxaban.
I can choose if the patient is, for example, less than 80 years of age, patient doesn't have any significant renal problem and significant liver problem and no GI upset, then yes, dabigatran can be an option of 150 milligram twice a day. If there is some renal impairment, probably apixaban will be a better choice. If the patients have more GI symptoms, probably we will not use the dabigatran. And if there is a compliance issue, I will try more probably going for a rivaroxaban because it's a single dose. So this kind of things I look into it. And
what is your practice, sir? Where do you place rivaroxaban in between these two? Rivaroxaban.
Now, if you ask my own practice, what I am doing for NOAC, most of the time for
yes, sir, yes, sir. Your experience sharing.
Mostly rivaroxaban, 20 milligram once a day, and if the patient has renal impairment, I reduce it down to 15 milligram once a day. So that's what I do in what I did for last few months. Some of my patients are on apixaban as well. My dabigatran patients are relatively.
Sir, your personal experience with dabigatran, side effect of dabigatran, your personal experience.
Sorry.
Sir, your personal experience of side effects of dabigatran.
No, not really.
Regarding side effects of
I didn't have any major bleeding from dabigatran for my patients as far as I am concerned. But I must say that among the three, my maximum experience was with the rivaroxaban. Among the three, that is my own personal practice, and of course, I have huge experience on warfarin, so which I have been doing for last 20 years.
And sir, any bleeding experience, when bleeding side effect in any of your patients on DOAC? Any type of DOAC, any bleeding experience, major bleeding?
Major bleeding, yes, in two patients. One had a GI bleeding with rivaroxaban. He was taking as a GI bleeding, significant GI bleeding. And another patient, I can't remember at this moment, but there are two patients who required hospital admission for bleeding. For the last few years, I am using NOACs.
Sir, as far as my my practical experience goes, if you allow me to make a point, that GI side effect, particularly dyspepsia, these I mean reflux symptoms, these are pretty common with dabigatran, and these are very troublesome for certain patients. And I have seen that because I have switched those patients in dabigatran because the cost has come down for dabigatran initially. Their GI problems were persisting, and after shifting them to rivaroxaban recently, it has disappeared. And it is very troublesome for me, and the frequency is not less. Almost maybe 2 patients, 20% patients have given dabigatran. They complain of significant dyspeptic symptoms, and the symptoms disappear after changing NOACs. So that is a problem that I have faced, and not only theoretically but also in practical usage that I have seen troublesome dyspeptic symptoms with dabigatran.
Okay.
One comment, that is our patient, if you see this case, the patient has been suffering from ischemic heart disease, and when you choose which NOAC will be the beneficial, again, I have an opinion again that there will be the definite toss-up between the dabigatran, rivaroxaban and apixaban. There is some advantage of using the rivaroxaban, some advantage of apixaban and dabigatran. The one thing that I will just, if the patient is having history of MI and the patient is having an atrial fibrillation non-valvular and the patient is having history of again the stroke, whether the recent evidence, if you see the rivaroxaban in the acute coronary syndrome, if you see the ATLAS trial and the COMPASS trial with the 2.5 milligram twice daily as a maintenance therapy. So already the patient is taking on aspirin along with we have to give the. So in that case, whether we will just go for the rivaroxaban rather than the dabigatran, that is one question I'll ask you. And the second is, if the patient is having the creatinine tolerance or eGFR of less than 15, and in that case, whether we can use the NOAC, because in any of the study, the NOAC is not indicated for the patient with eGFR of less than 15. In that case, we have to definitely go for this warfarin therapy. So what is your opinion, Dr. Majumdar?
As I said, this if the patient is the renal failure less than 15, yes, warfarin definitely. And another thing, valvular heart disease, particularly prosthetic valves and things, I don't prescribe NOACs. It's always warfarin. These are the two indications. And actually, in the valvular heart disease, in prosthetic valves, NOACs are detrimental. You shouldn't be using those. So these are the indications for giving warfarin. So
about ischemic heart disease and also the recurrence.
The evidences are coming for the rivaroxaban. Now that you mentioned about the COMPASS, that was particularly on the stable angina and the 2.5
yes,
milligram 2.5 milligram twice a day.
Stable angina but high risk patient.
That is a high risk stable angina patients. But in the ACS rivaroxaban, I am not aware of any particular study. But particularly,
yes, there is ATLAS TIMI trial. Yes.
ATLAS study is there.
But it was a failed trial. I mean, a negative trial.
A negative trial. Yes, not a successful.
Yeah.
So successful failure trial.
Dr. Bera,
those patients, you do a stent, you do a dual antiplatelet, and patient develops an atrial fibrillation. So we always get this kind of patients.
Exactly.
Dual antiplatelet, and you are getting an atrial fibrillation on this patient, so you have to give rivaroxaban on that patient. And we have a nice protocol now by the ESC. So how long you are going to use the 3 anticoagulant aspirin, clopidogrel, and the rivaroxaban? What should the length and duration, depending upon the clinical conditions? Either it's an ACS or it's a stable angina patients. But eventually, after 1 year, all these patients should be on the NOAC rather than on any other antiplatelet agent. If the patients have an atrial fibrillation and you had stents or ischemic heart disease. So this is kind of pretty standardized at this point. So these are the situations where you use rivaroxaban on the top of the other antiplatelets that we are using. So that's, I think I tried to answer those questions. If Shilanjan and Navarun has anything else.
Yes, I'd like to make one point to, address the question raised by Dr. Bera, that Mridul Babu, if suppose a patient is having atrial fibrillation with ischemic heart disease, either whether you have to anticoagulate, give patient DOACs at a dose of anticoagulation. You cannot give rivaroxaban 2.5 milligram BD.
No, yes,
patient automatically becomes a candidate for therapeutic anticoagulation.
Yes.
So you have to give, you are using DOAC, you have to give rivaroxaban.
I don't want to give the patient the 2.5 milligram twice daily.
No, you cannot give it. You cannot give it. You can only give it when the patient is in sinus, not non-AF patients. Then you can consider vascular dose of rivaroxaban.
Yeah, as the evidence is coming in favor of rivaroxaban in acute coronary syndrome, that's why I'm
not like that because it is working in acute coronary, chronic coronary syndrome after 1 year with low dose aspirin. There will be some added benefit in regarding anticoagulation. Anticoagulation will be in therapeutic anticoagulation in AF is a different ball game. So in that case, you have to choose. You can choose any of the molecules depending on the patient scenario that we discussed. Any of the molecules, be it dabigatran therapeutic dose anticoagulation or Riva 20 or apixaban 5 BD, can be chosen with clopidogrel up to 1 year, and after 1 year. And after 1 year, you have to continue with only DOAC as far as the recommendation goes at present.
Okay, thank you very much. I think we have already over the schedule, and then thank you for your comments and thank you for the discussion. So if we just summarize that non-valvular atrial fibrillation is a real problem, and prevention of stroke is very important if the CLAD/SWAS score is high. And here the NOAC is coming as a class 1 agent as far as the non-valvular atrial fibrillation is concerned. And depending, apart from the non-valvular atrial fibrillation, other conditions like valvular heart disease and prosthetic valves, still warfarin is required. And there are 3 options that we have now in our country. One is dabigatran, apixaban, and rivaroxaban. Each and every agent have their place in the management of anticoagulation as far as the stroke prevention is concerned. And good old warfarin also has certain roles in certain situations. And we have to take into account the patient, the risk, and risk of bleeding as well. And we have to prescribe accordingly to give the best results to our patients. Thank you very much, and thanks for organizing this. And back to Dr. Mr. Bose, if you have any comments regarding this.
So we will straight away go to the vote of thanks. First of all, we take this opportunity to thank our respected today's moderator, Dr. Vikas Majumdar sir, for best possible way of conducting this debate and ensuring the audience are enriched with clinically relevant messages. I also take this opportunity to thank Dr. Shilanjan Roy sir, Dr. Midul Bera sir, Dr. Manish Shah sir, and Dr. Navarun sir for sharing your valuable clinical experiences. We would also like to thank all the doctors who are attending today's antithrombotic debate. And we at Alkane, we always are available to serve your patients by making our product Picavic, Deviclot, and TSAT available in and around the city and state. And I take this opportunity once again to express my sincere regards and thanks for participating in our antithrombotic update. Thank you so much and good night, sir.
Good night.
Thank you.
Thank you very much.
Thank you, sir.
Good night,
Good night, sir. Take care.
Good night.
Thank you. Good night.